You all spread out a little more? That's pretty good. Got the whole room taken. Is the temperature okay, or we're starting to feel like we're back in New England? But okay, so welcome to our summit. I have a conflict of interest. I'm on the panel, but I'm going to introduce the moderator, Kate Berry, who's the Chief Executive Officer of National eHealth Collaborative, a public-private partnership that works with its partners, including the Office of the National Coordinator for Health IT and the U.S. Department of Health and Human Services, to engage stakeholders in a collaborative way to realize common goals that lead to transformative change. Kate has more than 20 years of healthcare experience and is a nationally known expert on electronic prescribing and a sought-after speaker on related topics. And there's much more of the bio that you can find in the program. I'll turn it over to Kate.
Thank you, Bruce. And good morning, everyone, and welcome to the opening session of the 2011 Summit on the Road to Interoperability and Health Information Exchange as part of the annual World Healthcare Congress on Innovation and Technology. Again, I'm Kate Berry with National eHealth Collaborative. And we actually run a number of programs, including NEHIC University, which is a web-based education program, and we offer a wide variety of education programs. And we are having a lot of programs this semester, in particular on health information exchange. We also convene something called the Consumer Consortium on eHealth, which is a group of over 200 diverse healthcare organizations that are coordinating an outreach and education campaign to get consumers more engaged in health IT. So we do, as Bruce mentioned, work very, very closely with the Office of the National Coordinator, but we are an independent nonprofit organization. So as chair of this summit, I'm very excited to have the opportunity to moderate a number of different panels. And this panel is focused on EHR adoption and optimization. So I'm just going to jump right into introductions. And first of all, we have Rebecca Armato, who is Executive Director of Physician and Interoperability Services at Huntington Memorial Hospital. And she's on, I think, every panel for the day.
They just figured they flew me out.
That's right.
I'm going to make me sing for my supper.
So in this role, Rebecca runs the outreach programs to encourage over 1,000 area physicians to adopt health IT. And many of the physicians are, in fact, taking advantage of their Allscripts free e-prescribing service. We also have Bruce Metz, and he's Senior Vice President and Chief Information Officer of Lahey Clinic. And he has extensive track record as a CIO, including more than 20 years in senior management and executive IT positions. And then we also have Dr. Lyle Berkowitz, a practicing internal medicine physician who serves as medical director for IT and innovation at Northwestern Memorial Physicians Group, the largest primary care group in the city of Chicago. And with that, I'm going to turn it over to Rebecca.
First, I want to get a feel for who's all in here. How many here are representing hospitals that are helping either get their own EMR up or their physicians' EMRs up and interested in that reason? Hands up. How many here are representing physicians trying to get EMRs and using them effectively? And so everyone else is here because this is the better room than the other rooms and everything. I wanted to speak to a couple things, and I'm not going to go through all the slides that I had because people are laughing that I even have slides. But I do want to say that I was born in Missouri, so I'm much more of a show-me state in talking about what we're doing and how we're approaching it. And the fact that we are sitting here and saying that there are real things out there that you can do today to help optimize an EMR. And the comment I made in an earlier session about that inside the walls, and what most EMRs focus on is that 40% of effort, because that's easy and that's what they know. But the reality is the real care and the exchange and the information that's needed to make the EMR valuable and optimized is that care that's before and care that happens after the patient is in the practice, and all the effort and spend around getting that information. And the fact that you can the fact that you do have to look at EMR adoption in a certain way. And also, we're taking and seeing physicians going to the next level of, can documentation in an EMR or in the community for coincide at the same time as the patient referral and payment. So to this date, most documentation was around getting paid for what you're doing. Now that we're moving a bunch of information around and sharing and using EMRs, what I'm hearing more and more is physicians trying to read or consume that information and going, I'm getting this 4-page note, and there's really only one sentence I'm looking for in that note from another doctor. So the reality is, how can we make people's use of technology effective and efficient so that they're not just templating a whole bunch of pages and we're still no better than we were a year ago and getting paid for incremental care. So we're really trying to work with how do we make that documentation consumable in that EMR so that it's usable and people will reach for it intuitively. If any of you are out there, we do have and have been very active in our e-prescribing initiative. It does have an iPad and an iPhone app, and when we're going around and helping physicians in loading that, and these are the guys that say, I can't use technology, it has no value. But every one of them have Angry Birds and a whole lot of other apps on their phones. And somehow they figured out the time and found the time to learn those things and play with those things. And we're trying to say, how do we help the vendors and the community get to that kind of use of an application in a way that's very intuitive and causes them to pick it up and start using it. When we started deploying e-prescribing, I didn't have to do anything. I loaded on one machine for one doc, and it took off on its own. The doctors walked around, and the next doctor walked in. 2 minutes, they're off and running. And so the reality is, can we do that with EMRs? And some people challenge and say, no, it's too much information. But the reality is, I really do believe that it can get there. And I'm not going to go through the different activities on an EMR adoption, but our message is it's not a spectator sport, and there's still a lot of physicians and a lot of hospitals that feel that consultants can come in, deploy it, and walk away, and they can start using it day one without any engagement or activity. And that is not the way this is going to happen. That's not the way it's going to be successful. And the reality is we have to, all of us have a responsibility in helping really address that in an engaging way and an informative way, but there are real savings when you do that. And this goes to the cost of an EMR. And there are physicians saying, I can't afford one, and I'm saying, how can you afford not to in running multi-million-dollar businesses, even for the small physician office? And we documented in baseline that the average monthly savings is somewhere between $400 and a couple $1,000s per doctor on a monthly basis. That's real hard green dollars. And then you get to the hours saved by you and your staff. And the $44,000 over 5 years really only equates to 2.5 hours of a $13 person and about 15 minutes of a $100 an hour person, which is a physician. So the reality is you don't do it for that. You do it for where the real true savings is going to come out of your practice and what to look for, and how you pick a vendor that is really going to work and meet with you to help make that valuable. And then it gets to that whole sharing and exchanging of information, which is really why we're all here, and how do you do that. And I just wanted to show this one slide of what it means in a reality sense of saying, here's your EMR, you've got data pushed into your EMR that you're using every day, and yet there's a button that gives you a view into that community view so that you can, without requiring it to all come into your EMR, look at the information that's in the community, identify lab tests that may be totally normal that you would have run, now you don't need to run. Do you really need to bring that data into your EMR? Probably not, to make that decision. What you want are certain other key factors that you may want, and yet the language of who populated that may have come from one EMR with a different vocabulary in another. But by giving you that visibility, you can check the information you want. You can click a button and import it into your EMR, and it comes into the EMR, translated into the language of your EMR, since there aren't standards yet in vocabulary and definitions between all the different EMRs. And so the reality is, how can we create a single electronic record in a virtual environment among multiple vendors? It is a reality, and it can happen. Not without a lot of work, not without effort, but nothing ever worth having ever is. And so I just wanted to show a real-life example of what can happen with that. That's it.
Very good. Bruce?
Great. Those are good slides. Yeah. Thank you. Well, good morning again, everybody. So let me just make a few background comments. I've joined Lahey about 6 months ago in my current capacity. A few months before that, Lahey hired a new CEO, a new COO, and we also have a new CMO. So a number of the strategies and activities that I'm going to talk about are really new that we're putting in place. Some, in fact, due to what, if you were here when I made the opening comments as the chairperson, given just the huge activity that's going on in Massachusetts, which is a little bit out ahead of the rest of the country, given healthcare reform that Romney forgot happened when he was governor in Massachusetts, but just a real heightened activity of mergers and acquisitions, and people are moving around really fast. A lot of organizations are not really sure where they're going. But the tsunami that I talked about this morning of when the federal government makes draconian cuts to Medicare and Medicaid, which is going to happen, is going to be a real bellwether for a lot of places. So there's an unbelievable amount of activity, and I keep checking my email today to see if we merged or bought or became affiliated with anybody else, because it happens almost daily, and there's quite a presence also of for-profit corporations that are really, for some reason, looking to get in the healthcare business. So with that backdrop, let me just make three really general observations. One, as I'm sure all of you know, but wasn't necessarily so true back in WIT version 1 and 2, an EMR implementation is not an IT project. It's a clinical transformation project that's designed to really transform how patient care, safety are delivered. Leahy, unfortunately, before I came for several years, really treated their EMR project much more as an IT project, and so what begins to suffer there is the lost opportunity for really raising patient care to a new level, but physician adoption really suffers. So I'll be happy to go in more detail as we talk, but we've really had to reorient the entire project with the physicians and clinicians at the center so that it's much more participatory, and we really begin to apply evidence-based medicines and protocols as the standard of care. There was a comment in an earlier session about really getting the costs out of healthcare. Well, if you're going to try that, one of the major cost causes is the huge variation of care. Same disease, different treatment, different results. Same treatment, different results in different geographies. And the only way to really standardize that, if I could use that word, is to introduce evidence-based medicines and protocols, which we're now doing. But having said that, we really have three levels of strategy with an EMR that, given the movement toward ACOs, which some people say they've never seen an ACO, although CMS just came out with the final ruling for accountable care organizations, is a high degree of integration and use of evidence-based medicine within the walls of Leahy. So that's within the clinic proper. Leahy is an integrated delivery model where the physicians on the ambulatory side and the acute care side are really one and the same, and where there are somewhat different clinicians, they actually really work together. And Leahy, founded in 1923, somewhere between then and now, takes credit as the first organization that had an integrated paper chart. Some physicians really wanted to maintain their integrated paper chart, but practicing on an integrated basis is really in the DNA of Leahy. So having a highest degree of integration possible within the walls is actually key. Then we have our growing affiliates and partners in other hospitals that will come within the Leahy system that forms our immediate community. And so we have a whole other strategy about how to share patient information and to foster collaboration among clinicians in that group. And then the third tier will be referral sources and other entities that we have to deal with. And all of those have some degree of commonality in terms of the infrastructure that we're using. But there are differences in what clinical integration requirements and other clinical needs are for the EMR, so we're developing a strategy around that. The third area that talk about that often isn't discussed is really the nature of the EMR and the technology itself. Relative to other industries, banking, business, or finance, health IT is really relatively immature. I mean, health IT has been an underfunded area for a long time, really to the credit of the federal government of pumping $32 billion into the whole EMR space. has really jump-started a lot of vendors and a lot of interest and focus on EMRs. But relatively speaking, this industry that we're in is got a long way to go, and it has to catch up in a fast time. So for example, if you looked at commercially available EMRs that cover the acute to ambulatory space that exists on a modern technology platform, the same that was true 5 years ago is true today. There are 0 of those out there. Nobody's really developed that commercially yet. There are some that are more integrated than others, but their technology is relatively old. And that's a big deal because that's going to hit a wall at some point in time. Most of this technology is also developed from the inside out by software developers, not from the outside in by clinicians and physicians. So if you look at Apple and the success with an iPad, that is so successful because it was developed purely from a product point of view with consumer. And the way Apple works is they have the overall human factor design, then they hand that to technical folks and software developers and say, here, you figure out how to develop this, not the other way around. And so what we have is really a point-and-click system with, as Rebecca mentioned, tons of different vocabularies and nomenclature. There's only so much that a physician can do to adopt that level of technology. There's only so much you can do to try to work around, click here, point there, go from screen to screen. So when you get into clinical transformation and implementing an EMR, 75–80% of the project has nothing to do with technology. It has to do with workflow, training, support, and changing the way clinical care is practiced. The only way that's ever going to change is when there's an entire new user interface for EMRs, such as voice and other levels of context development, which are in progress, and a new generation of EMRs hits the market that are designed from the outside in and by clinicians for clinicians. So what we're doing at Lahey is understanding those limitations and really paying much more attention to workflow, roles and responsibilities, building up the care team with mid-levels, nurse practitioners, and those kinds of skills in order to enable a physician to practice at the top of his or her license.
Very good.
Okay. So I won't take any offense or read into anything that the doctor is sort of at the end of the line here to the IT people. And these guys, you guys actually, it sounds like work with physicians. You don't do things to physicians, which I really appreciate. So I'm a primary care physician. I still practice part-time. Still have an active practice, but I'm part of a larger group, which makes it a lot easier for me to be able to do the other things I do. I wear a couple of hats. I am the medical director of IT and innovation, because as we've heard, it's no longer just about IT. I've spent a lot of my time on how to innovate with IT and how do we change the process of how we take care of patients. And I also run a nonprofit program called the Solozzi Healthcare Innovation Program, which is designed to figure out how to creatively use technology to improve the experience of both patients and those who take care of them. And so that's been fun to have some extra time and money and energy to just completely be innovative and think outside of even traditional sort of IT and EMR innovation. Over the years, I've been involved with a number of startups as well, so that's is also very energizing, interesting, and I think it's very important for us to be able to proceed and do things well. I've been involved in a number of national organizations, including AMDIS and the Innovation Learning Network and AHIMA. And with HIMSS, I've been very involved in the usability movement. So as was mentioned, I mean, that's very important. We have created EMRs that meet the functional specifications, but very rarely the usability needs of users. And it's really hard, yes, doctors love technology. We're not, we might like a game on the app, but that's because the game is fun. EHRs are like the worst designed game ever. And we have to figure out how to make them a little more fun and usable. And we have to think how to task shift so that we're not, it shouldn't be all about how do we make it easier for a doctor to use it. It should be at a systemic level. How do we make the system easier so, in fact, the doctor doesn't even have to see certain things? that doesn't even get to their plate because we can task shift by using technology. Every other industry's done it. We have to start thinking about it more. It's hard because of various policies, governmental regulations, etc., that somehow all too often require the physician to be intimately involved, but sometimes that's just cultural as well. Kaiser has shown that when the incentives are aligned well, there's at least 30% of visits that would normally be done in the office can be done virtually by extended care teams without having the physician directly involved. Our group is about 100 plus doctors, primary care focused, throughout Chicago, 15 different offices. We went live with the EMR that we use from Cerner in 2002. We've rolled out the typical notes, results, messaging, orders. We also now do all practice management, and we have a patient portal we use from Relay Health that has over 60,000 patients signed up, and we now have, as on a campus of around 1,500 physicians, way too many EMRs, but it is what it is. 5+ EMRs bubbling up, and the enterprise approach and strategy is to use yet another vendor to sort of unify those that data into a single view, so that in any one of the EMRs you can jump to a single view to look at the notes and other information from the other EMRs. Not ideal, but that's the process that we're moving to. And as we bought another hospital, we're in the process of merging with another one. As we expand to others, there's going to be more and more IT systems. So we have to figure out how to make that data easily usable. In terms of EHR adoption, I wrote a chapter in the ACP's book on EMRs called Physician Adoption Strategies. It's something I've been involved in a long time. And I'll just throw out a couple of thoughts really quickly. One is to understand your physicians. We did needs analysis very early, because if you can understand the bottlenecks and frustrations of your physicians and figure out how the EMR solves those, you're going to have a big leg up as compared to going in and telling them what it solves for them. Find out what they're frustrated with from the start. We did surveys, found things like, as Paul Tang mentioned earlier, a number of 80+% of the time when there wasn't some piece of data or the chart itself wasn't available. We educate constantly. I'm sending out FAQs and other emails all the time about setting expectations and educating doctors on how to use the systems. We optimize by looking at report cards of how our physicians are using the system. And when those who are not, we look at positive outliers, why they're doing well, certainly negative outliers, and in a systemic way say, what are we not doing? What haven't we not taught them? How do we work with them a little more closely and give them some extra attention to make sure they're completing their notes, using the med list appropriately, etc. Leadership is the number one thing that makes these things work at executive level. Strong support, as well as at the physician level, having champions in each of the specialties and empowering physician leader to be involved with both the build and the rollout of these systems. And then finally, I'll end with something we hear a lot of, which is the idea that the EMR is more than replicating the paper system. It is a form of process innovation. It gives you the ability to think about process innovation. A couple of the fundamental tenets that we believe in are that, one, physicians, there's not a shortage of physicians, of primary care physicians, as much as there is a shortage of using them efficiently. Right now, in our current system, we have the physician doing everything, every piece of paperwork, touching every patient all the time. That can't continue. We're never going to have enough physicians to maintain that. But the good news is we're starting to think in team-based care. We're trying to align incentives that way. Technology can certainly help us do that. And as we do that, we have to take the stuff that's assembly line, that's routine, same thing every time, and push that off to lower level staff. Because it turns out they're actually better at following checklists and rules than doctors are. Doctors are really good at the higher order thinking, and that's where we need to use them the most. We also have the philosophy of making it easy to do the right thing. Rebecca mentioned earlier that sometimes it's hard to do the right thing, but we keep trying to figure out how do we make it easier to do the right thing. Because I consider myself a really lazy physician. And how do I figure out, how do I get someone like me to do something? It's if I can get something off my plate, if I can do less work, but have someone else on the team do the work correctly, that's a big win for us. And I'll talk to you a little about how we've done that. Some of our major successes, we've done the typical stuff. We've eliminated the charts, which turns out to be our biggest ROI. The fact that we don't have huge paper charts in our offices. They were smothering our offices. We were spending a lot of time and money, not just on assembling these charts, but actually the space. Now we have offices where we have extra room to employ more physicians. So one of the metrics to look at, I'd encourage you, is the amount of revenue generated per square foot of office space. Because once you get rid of extra, all the extra charts, you actually can generate more revenue. We also, of course, make it easy and to access the records across our whole enterprise in a legible way, and the result is that all of our doctors can take care of any of our patients at any location, as well as our central administrative staff can do the type of billing and care coordination that they couldn't do otherwise because they have access to our records. So let me talk about care coordination. We have a care coordination team. It's actually a virtual team. Half of them work at home. Doesn't matter because we're all online. And the result is they're our traffic cops. And I use that word COP because we use them to help with consults, orders, and what we call pathways, which are often a combination of things. And we use that to address what I call fire drills and black holes. We talk a lot about preventive care and disease management, but these fire drills and black holes are where we spend a lot of the money and where a lot of patients have the most risk for harm. Fire drills are, new diagnosis of cancer or new finding that needs to be worked up, hematuria, an irregular rhythm, a thyroid nodule. So our doctors now are able to send a single message from the system to the care coordination team saying, this patient's been identified. I've done the hard work, the higher level thinking, to come to this situation where I know there is this problem, I diagnosed it as a problem, it has to be worked up, but instead of making them go and look and find out what is the workup for each of these, we send that to the care coordination team with a checklist that they work. That checklist usually includes getting a test, setting up a consult, sending out patient education, doing a follow-up call or chart review to make sure that everything actually got done the way it was supposed to be done. The result is, we've done some IRB-approved research on this, we can actually improve the quality of care, we can make things happen in a shorter period of time, and we can save money for both the patient and the payers of care, as well as boost revenue internally because we get all the referral authorizations done and we get everything done that has to be done in the appropriate time. So we're real excited about the fact that you can use care coordination to actually improve not just quality but also the return on investment at an organization and cut costs for the healthcare system in general. We look at black holes also. Black holes are the patients who get lost somewhere. Whether it's a transition in care or they're poorly controlled diabetic, and we've come up with systems that we came up with a diabetes tune-up system, again, which we use the EMR to identify the high-risk patients, hemoglobin A1C over 9, and notify the doctor that they're having problems. The doctor then reaches out to the patient, and we've set up a system where we can get that patient in, get a higher level of education and work with the endocrinology specialist, and the result is pretty astounding. We get these patients who do agree to come in from hemoglobin A1C of 9.6, which is really bad, down to 7.5 within 6 months on average. Each 1% decrease, there's about 2% decrease, decreases risk of complications by 40%. We save the healthcare system a lot of money doing that. What we do know is only about 25% of those patients are willing to come in because they're a really tough crowd, and now we're going to do ethnography research on them to find out what made them come in and what made the other ones not come in. So it's going to be very interesting, but it's a way to use technology to identify and communicate on how to get folks in. We failed in a couple areas, or we're not doing as well as I'd like in preventive care because we haven't figured out how to make. We have the dashboard, we can show people, but we haven't made it as intuitive and as easy as I'd like. We failed a little in rolling out the EMR completely to our dermatologists because of how they work, but in terms of the internal medicine specialists, our pediatricians, the gynecologists, they use it routinely for everything. On the OB side, they're still struggling because of how difficult it is when you're seeing patients. When you got 1 minute with a return OB patient, it takes that long to open up the EMR. And so we're still struggling on those sides. So that's just quick review of, semi-quick review of what we're doing. Thanks.
All right, great comments. And we're going to open it up for Q&A. So if you have questions, please step up to the microphone, identify yourselves, and we'll open it up. But I'm going to start with a few questions to get the ball rolling. First of all, it seems like all of you were well underway with your EHR implementation long before meaningful use was introduced. Could you each comment on, how the meaningful use incentives, what the implications were for your strategy in terms of how you're deploying the technology and the clinical transformation? So did it have any impact? What was the impact? Starting with Rebecca.
Well, I was at Hoag before I came to Huntington, and we actually offered incentives and subsidy for physicians to adopt EMRs before there was a national. We like to think that Washington liked our program so much they adopted it for the country, but it offered a subsidy for 3 different EMRs, so physicians still had choice. And we knew it was to get to that practice viability and responsibility. The problem, while it's great that they've thrown all this money in, it also created a lot of noise to a group of people that are not used to being paid so much attention to, and not knowing necessarily who to trust and where to turn for information. I think I couldn't tell you if I had a dime for every time a physician came up and said, well, this EMR was developed by a physician. It's like, well, I think all of them had some physician involved at some point. But I mean, I think there is that that effort that we have to do to get everybody educated so they're making decisions for the right reason, and recognizing the difference between urgency and importance. And so it's great that there's all these resources out there, and it's important to help the physicians understand and get beyond, again, what's working just today to where does that EMR need to do and support in 3 years, because that really, people talk about the terminology of care coordination or ACOs or medical homes, and the reality is those are terms that have applied to what's always been going on for the beginning of time in an EMR, in a physician office, and all we're trying to do is create an awareness on how to do it more effectively. So I think that we've taken the opportunity to say, look, you can get incentives and money back for what you're doing, and that's a good thing. Why not approach it from that perspective? But we need to stay focused on where we need it to be, so that what you're deploying and what you're doing doesn't hit the wall, 6 months from now or a year from now, when you're realizing I brought the CMR in and it's not meeting my needs for both my patients and my practice and the community. So that's really how we're approaching to go beyond the attention that's happening.
Very good. Bruce?
Yeah, well, I think, LeAHEE we have adopted this strategy that one of our central focus is to use an EMR to help provide the highest quality, safest patient care that we can, with the highest levels of patient satisfaction at the lowest possible cost. And we take all that I said above seriously. So I think it's fantastic that the federal government is shining a light on the value of EMRs, putting $32 billion or so, and having payments for meaningful use. But for us, that just kind of confirmed what we were doing. And the meaningful use criteria would be sort of at the low end of what we would try to achieve anyway. Although having said that, there's nobody I've talked to who really would want to leave a significant amount of money on the table. We're not going out of our way to do anything different because we were doing that in the first place. Where I see a real change of behavior and a real connection to the economic incentive is more with the independent private practitioners in our communities who, as I mentioned in the opening, that's always been the lion's share of what American medicine has been about. And many, I don't know if you all have had the opportunity to interact, but many community physicians that I deal with are business people. I mean, they really value their independence. They really take a lot of pride and value the business that they built up. So for them to get an EMR is an economic decision. And we're finding that we're able to really have a much more open dialogue and talk about how we could develop a stronger relationship and connect community physicians, since they have the meaningful use opportunity and the subsidy as a cost to offset what an EMR would be, which is non-insignificant. So there I really see that's changing the behavior. But for us internally, to Leahy, we're going to keep doing what we're doing because we're doing it anyway, and really use that as kind of the low end of what our goals are going to be.
It had a little bigger impact on ours in the perspective that we were on the older version of the EMR. And eventually we're going to go to the newer version, but it gave us, and gave the organization an imperative to move, and we had a date in mind, and that's how things happen a lot of times. I mean, the government did it to stimulate, and it did that. It stimulated us to get on the ball and hit those targets and get everything rolled out on time. It also pushed us to do a few things like smoking status, which our EMR vendor really didn't have a good way to do that, but we had to figure out how to do that. It churns the wheels sometimes, and we wind up spending a little time on stuff I wouldn't necessarily want to spend time on. But it got us moving in the right direction. And one of the interesting things, I was interviewed recently about apparently there are a group of people who were upset that people who'd already adopted EMRs were getting funding. And that's not fair. I'm like, what are you talking about? It's a really good message to send that if we did the right thing early on, we should still get rewarded. And two, it's not like this is a slam dunk and we just put out a hand. It took a ton of work to get us up to the level where we can do meaningful use. But at an organizational level, our hospital, like many others, is offering an EMR to the providers, and some of them are taking that, some have gone with other EMRs. But the fact that there's that money out there certainly helps. It's not the only reason people do it, but it certainly does create an incentive to look that way and to move that way and to feel more comfortable about going there.
So we have a question from the audience.
Hi, I guess this question is for the entire panel, whoever feels interested in answering. So I work for Covidien. We do, I'm on the medical device side actually in the hospital. And so we're interested in kind of how this is moving and how patient data is going to be used. And so very interesting conversation. I have a very specific question about the EHR, EMR certification process. And I know Cerner has one, so if you're not familiar with how it works, me as a medical device company would go pay some money to have Cerner kind of certify the connection between the devices and the EHR. I was wondering what you guys thought about that being a requirement. Is it something that helps you as a hospital consumer, or is it something that we could kind of prove and validate and kind of service on our own? Does that make sense?
Well, I'll start. I mean, I guess because I've been working with the CCHIT and certification before there was even really a need for certification. It was more started before the federal government realized, and I think it is an unpaid position. It's a choice that they come and ask for you to get involved. But it helped identify and set some criteria in place in a marketplace that doesn't have standards in everything. And there has to be an awareness for people making these investments that things will work together. Even if we're just getting to the data level versus the content level, there's got to be some rules and oversight in that activity, or people are going to invest in technology that don't talk to each other, that aren't interacting with each other, and then there's no value in this technology. The whole idea of innovation doesn't mean anything if that innovation doesn't do anything for you, and that's a real statement. And I think that kind of approach of certification of devices, working with different applications, one, it gets you an understanding of if you invested in an EHR like Cerner or something, what technologies that organization's committed to working with in devices to help make it more effective and efficient. But I think that's going to end up becoming something, much more national and global, whether it's FDA or whatever, that it's going to become one of those things that right now are getting attention, but then it's going to be assumed, that things are going to work together and be interoperable. But it is a way to get moving in that direction and getting a commitment. So I know for our physicians, and we teach them, we do on the readiness assessment, what kinds of devices do you use, and then be very clear with the EMR vendors you're talking to about their ability and willingness to interact and interoperate with those devices. One, to take if it's possible, leverage the investment they already made. I'm not about throwing out everything and coming in with something all new. But two, that it's those data capture devices, that's really what's going to transform what we're doing, getting to the point that it's not all about somebody just keying data in. How do we help this all flow automatically so that then everybody is doing something much more intelligent, a much more higher educated level with that information versus the actual activity of just keying data in because the devices don't capture it appropriately. So I think it's a requirement, and to our physicians, it's certainly something they're looking at and evaluating when they're selecting EMRs.
Yeah, I'll just add from just a clinical perspective. It's fine for me if the market makes those decisions. I mean, if you're a company that has a device, an app, etc., I think it's great if the EMR companies have an easy way for you to connect with them. We're seeing traditionally there's been many more devices in the inpatient world, but I think we're going to start seeing with the quantified self movement. I'm already seeing wristwatches and apps, etc., that quantify the outpatient as Mapolis or whatever that was, that type of thing. We're going to see more of those, and the more that the EMR companies can embrace the innovators that are out there and work with them and create open API and other systems for communications, the better. Whether or not the government needs to be involved, I'm not particularly sold on that as much as I think the market will dictate that with respect to getting that information in and getting it in not just as a blob, but as something that can be usable. I don't want to see 5,000 data points from a blood pressure machine or a glucometer. I want to see some type of level of clinical decision support that takes that data and presents it to me or my staff in an appropriate way. And the more the EMR vendors can work with the third-party companies, the better.
Yeah, I think just to add to that, because I think those both well said, the need for interoperability is so huge. There has to be some quality control, some standard certification setting for this to really happen in a meaningful way. There's going to be this avalanche, if there's not an avalanche of information already. And, go back to this morning to what Todd was talking about with all these different exciting projects that are generating huge amounts of data, and healthcare is becoming an information business. Unless there's this kind of way to facilitate a level of interoperability, it's going to be impossible for physicians and other clinicians to have easy access and meaningful access to information at the point of care. I kind of lost count of how many EMR vendors there are. There were over 60 EMR vendors. They're all not going to be standing, but one sign of an immature market is this proliferation of vendors. So if you look at the business market, which is probably business software market, 10 to 15 years ahead of the health IT market, years ago there were several ERP, enterprise resource planning system vendors. There's really now two main ones, Oracle and SAP. So the 60 may not go to 2, but it's sure going to go closer to 5 than it's going to be to 60. And the same is going to happen with other vendors in different spaces within the health IT industry. And so one, you want to make sure you're going to be connected with one of the vendors who survived. And I can guarantee you the federal government is not putting $32 billion into this activity to have a good lion's share of that money wind up with vendors who then aren't going to be around after folks have purchased their software. So the whole standard certification process is huge, and never a clear way to do this, but if you totally let the market do it, the history in technology is you have standards, but different vendors implement them idiosyncratically, so you still don't have interoperate. So Sun, years ago, created Java as kind of the web programming language, and then Sun and Oracle and IBM and Microsoft, when Sun wasn't part of Oracle, got together and said, let's implement a standard for Java across all these platforms. They did, but there was no federal or other kind of control, so everybody implemented the standard differently. And so Java programs on a Microsoft machine didn't interoperate with Java programs on a Sun machine or on an Apple machine, even though there was a standard. So to really make sure this works, which it has to because the amount of information in healthcare is going to be enormous, it's complicated, but it's absolutely critical.
So can you each comment on, how you measure the success of your implementation of electronic health records, and can you demonstrate a return on your investment? Anyone?
I mean, maybe because we're doing it every day with a different practice, so we're in a different scenario than these guys that have started and been the thought leaders out ahead of everything. But we baseline the physician offices. We look at their expenses, true cost, and spend for the previous year leading up to the EMR implementation, both in hard dollars and staff and salaries. And obviously the easiest thing for physicians to get their head around, and believe me, I love doctors, so I'm going to say that, out the chute. But the easiest thing is what comes out of their bank account every day. So they're paying money to buy supplies, they're paying money for payroll, and that's understandable to them. So we baseline those real costs. What they don't see necessarily is what that payroll is going toward and what those people are doing with their time and how they're spending their time. And so we're also capturing and created tools to help those physicians and ourselves on their behalf capture those costs and time now on what they're doing on particular activities. Then they go live and we address and make sure that with the vendor they're focusing on the right pieces. We're kind of like our own rec, only we're not taking money from the feds. We really felt it was the investment we need to make in our physicians because we needed to help both the primary cares and the specialists equally. It wasn't about just helping the primary cares, and we wanted to have incentives. We didn't want to be driven in one way or the other on who to help first. But we identify then after they go live, the first 30 days, 90 days, 6 months, a year. And you need that kind of reminder back to them to say, this is what you were doing before, and yes, it was hard. And believe me, you don't want to ask anybody in the first 90 days if they like their EMR, because I don't care what it is or who it is, they don't like it. But we, and sometimes they forget what they were spending before. So I think it's important that we provide that feedback back on, and here's what you were doing before. It takes about 6 months to get through that. But there really is a true value in adopting the EMR in real dollars and that monthly savings. EMRs themselves, I mean, one thing the competition has created is there is a reduction cost in EMRs and what they're doing today or what they're charging. The impact of that interoperability and that exchange is a huge piece of that cost. And so we are demonstrating real value in dollars and cents. We did on ePrescribe alone, on just ePrescribing and what the savings were to the practice in time and effort involved in just doing that is a one function. To say you can pull out a function of a practice and do something that's very disruptive and still provide value, we were able to demonstrate that too. And we've made that just part of what we're doing to, one, help physicians understand that there is a reason to do that investment. And I'm just excited where we end up being when we get the majority of people really optimizing and that liquidity of information and flow and that single view to the end user experience and what we can do a year from now when we're all much better in a place of that, having information in a usable format. So,
yeah, I think I'll chime into that. I think that's great. We measure this in a couple of ways. 5 years ago, 4 or 5 years ago, I'm trying to think back, an EMR was kind of a strategic investment, that it would be a competitive advantage, it would be a differentiator with other organizations in the marketplace. And what happens in technology, what's strategic yesterday becomes a commodity and just an operational necessity today. So today, an EMR isn't strategic. So if you want to stay in business, you have to have one, because you won't be able to get paid, because you're going to need to report against quality measures, and you need to fulfill a whole host of compliance requirements. You can't possibly do that without an EMR. So in some levels, there is no need to quantify, justify what's the return. It's either be in business or not be in business. More strategic today would be health information exchange, clinical integration activities, the ability to really do informatics and analytics quickly in a way that goes beyond what other organizations can do. And that in 2-3 years is going to become a commodity. But having said that, there is still some immediate returns that you could try to capture. And I think you mentioned one of the big ones is when you do away with the paper charts, all these rooms are now opened up. And what we've done in prior organizations I've led as a CIO is convert that into clinical space. So now all of them have new opportunities for revenue. And there are other activities that one could do like that. But basically today, I mean, this is just such a necessity that if you really have to convince either executive or board level management about this, then the organization has some other level of issue.
I mean, I'll add, in many ways we don't measure ROI as much as we, from 10 years ago in 2001 when the decision was made, we have to do this. It's the right thing to do. It's a little easier for us because we are a physician or hospital-owned group, so we are subsidized to some extent and protected to some extent. Our doctors, are making money based on seeing patients. It's not completely, they're not the ones who had to pay for the EMR specifically, so it's a little different than where you have to show them. And you're right, they forget the stuff so quickly. They can, anything bad happens with the EMR, they're all over you. But when you remind them, when they talk about paper in a nostalgic way, how great it was, and you try and remind them, remember you couldn't find the chart half the time? No. But it is good to bring those things up. But we had such an executive commitment to doing this, it just pushed through it. What we found often was on retrospect. And one, though, we didn't really have the resources to even do ROI. I wanted to do some. I had some ideas for it. I had metrics plotted out. But we're just too, we had too few staff to even do any significant ROI. But we know that the paper, having the chart out of the office did well. But there's one example that actually wound up working out really well. And it's because we had the foundation for EMR. We didn't know. There's no way in 2001 or 2 we could have predicted what would have happened. But starting about 2005-ish, we started sending electronic orders, and by that I mean literally a message to our referral team to say this patient needs an MRI. Because they would then fax that message to the radiology, so not particularly high tech in any way. But the result was that by doing that, the radiology department would get the order, would have it there, and they'd less likely have to bother the doctor about it later on. They would actually, the radiology department would call the patient to set things up, which made it more likely the patient would do it. And then something we barely thought of, just sort of happened, was said, while the team that is going to do this, they said, can we do the referral authorization before we send it off? That way we'll make sure we don't, we get that taken care of, then the patient doesn't have to call them to ask them for the authorization. Great idea, fantastic. We could have done that on day one, but we didn't realize till after a couple of years in, hey, that makes sense. And we did that. So super easy for the doctor to send the message off, much easier for the patient, more likely they'll get done. And then it turns out, we looked at the stats 2 years later on retro authorizations. Retro authorizations are a big pain. That means that someone got an MRI, didn't get the referral authorization ahead of time because they forgot to call. And the result is, a lot of the time, the hospital doesn't get paid, and or a referral team has to work like hours and hours to try and get this retro authorization done. It's often denied. Big pain for everybody. Well, it turns out we were doing about, in our group, like 25 a month of those. And we reduced those within 2 years down to about 1 a month when people didn't use the system. And the result actually not only made life easier for patients and our referral team, saved the hospital millions of dollars. Which, by the way, if you want to get a VP's attention at a hospital, save them a couple $1 million. Because now all of a sudden they're like, hey, we like this thing that you're doing with the EMR and the care coordination, and we want to fund that. We'll put that on our dashboard. And so that was sort of an unexpected, benefit of doing what we. So now the past 4 years, we spent a lot of time in building a whole care coordination infrastructure well before ACOs, et cetera, came along. So we've been doing that, and now we're prepared for that. So sometimes those things just happen by, again, doing the right thing, but having that infrastructure that what allows you to do what you could never do on paper.
So we're going to do one last question, and then I think we need to bring it to a close, or we're going to get further and further behind all day. And I think Bruce earlier mentioned the accountable care rule, the revised rule that just recently came out. So if you guys could sort of look forward in the next, let's say 2 years, what's the next phase of your technology deployment and clinical transformation strategy? Are there new capabilities that you need to have in place to be successful in that new environment? Or, what's the next couple of steps from your perspective?
Well, our whole path, and just as a reminder, I am an employee of the hospital, and the fact was I am blessed with an administration and a board that recognized the need to invest in things that improved quality, figuring that if you're going for the right reason and the health of the community, then you get a financial return. And so the fact is that we are committed to helping and investing in technologies to bring to independent physicians to create that kind of seamless ability to become clinically integrated. And we are on a path to be clinically integrated. Perhaps the legal method, more important that it's more the way we all work and think and practice medicine. And among disparate systems, because that's the reality. We're not going to dictate one system. We're not going to try to force people in, round pegs into square holes. And we're sitting there going to say that we really are trying to create that infrastructure that translates and provides a seamless view in usable information and insights that improve and impact outcomes. And so that is where we're going. That is why we built, but you've got to get endpoints technically available. You've got to have a common infrastructure that can translate. Do we hope and expect a lot more standards in place someday in the future? Yeah, but that's not going to stop and cause us to wait until that perfect day happens. So we really are engaging in that kind of interoperability of an exchange of information to create that virtual view, that single virtual view, and across independent platforms. And that is where we're focusing on. And what's nice is that a bunch of independent physicians recognize when everybody sees the same information, you are led down the path of what are best practices. And right now I think a lot of best practices are subjective because they think they know what they did last time and what worked and how the impact was. But the reality is there weren't ways to really measure and identify what are those true best practices. So without forcing best practices, they're inherently and naturally coming out by creating transparency, visibility, and common translation of information in a way that's usable. So that is where we're going. And are there technologies that have yet to be developed to get there? Yeah, probably. And I think it goes to that user interface and becoming more intuitive and available. And, there isn't an Angry Birds of EMRs yet. But that doesn't mean that we can't do a tremendous amount of value today. And that's I think the technology exists out there. It's just a commitment to go out and do that and to bring everybody to the table to build that. But I think it's possible.
Yeah, that's great. I think that's a great question, framing it as 2 years, possibly 3 years, because nobody could accurately look longer than that, given all the unknowns, the uncertainty that we now have, and as complex as the issues with healthcare that we deal locally, let alone nationally. So for us, growth is, we're really on an active growth strategy, and so we'll be expanding the walls of Lahey. And so what Rebecca talked about, the whole area of clinical information integration is absolutely key. And there's so much time if you try to replace EMRs that other organizations and other physicians have. So the strategy would be, how do we integrate the EMRs that others may have in a way that's easy and meaningful for physicians to use at the point of care? There's some technology to help do that, but also some that needs to be defined. And I think, I mentioned earlier, I think that's much more of a strategic differentiator than having an EMR is at this point. Although at some point, this industry and what we do needs the kind of iPad transformation technology that completely changes the user interface for us to make a quantum leap in how physicians use EMRs and how we integrate all of that. But the other part I think we all got to pay attention to over the next couple of years is to really firm up the foundation that's in place. You know, I think there are these huge tsunamis around what the federal government's going to do with Medicare and Medicaid funding and what happens with physician and possible nursing shortage. But the other that really keeps me up at night as a CIO that isn't talked about a lot is we're taking the core business of healthcare organizations like AHI and others from paper to electronic. And do we have adequate disaster recovery, business continuity, and backup? In most cases, the answer is no. Either you outsource it to another vendor or you have all of this clinical information and the systems running in a data center. If something happens to that data center, that's almost like building a nuclear reactor on a fault line. But nobody would do that, right? I mean, that's pretty serious that there really isn't the attention, and it costs a lot of money to have an industrial strength disaster recovery system to go with the primary data center that our clinical information is going in. And that's really a crisis in the making that at some point is going to happen that we all need to pay real careful attention to and do something about.
And we'll give Lyle the last word on this.
I'll say, you know, there's so much going on. It's such an exciting time, but we're going to focus on, if I focus on the care coordination stuff, the fire drills and black holes, we're going to take what we do now, the infrastructure we've set up, the pathways, the checklists, and we're going to say, look, right now, you know, the doctor has a full plate. We're going to take as much as we can from that plate, figure out what we can standardize, what can be checklisted and put into a pathway. And you know, we're expanding, for example, we're going to roll out a low back pain, DVT, again, things that once the doctors sort of figured out, okay, you have low back pain, it's not a kidney stone, it's not cancer, you have musculoskeletal low back pain, now I'm going to send you to the pathway to run through it. Once we know you have a DVT, you don't have a swollen leg, you have a DVT, this is what we're going to do. We're going to do that more and more so that our doctors who are already comfortable with this and are going to be even more aggressive in using these pathways to start moving our care down to these care coordinators. And we've done it very cheaply because we don't need nurses. We just need people who can, administrative people who can read through a checklist. So we're going to expand it for our group, the number that we do. And second, what we're working on is to become a utility for our campus so that no matter what EMR you use across our campus, you can use the infrastructure we created. You can send a note from your EMR to our care coordination team using the same templates that we've created, the same pathways, that same checklist, and that they can run up. Because most of our groups of doctors, and particularly primary care and smaller groups, they don't have the economy of scale to do this. The biggest problem we've had so far is that we've done it so easily and cheaply that our lawyers are scared that we're somehow giving this away too cheaply, and that that we might be violating some law. That's our biggest holdup right now. The other doctors are waiting in line to be able to do this because they see it as something that makes their lives easier and makes the quality of care that they provide better. So we're super excited about using this infrastructure we have, even if it's not in the same EMR, to set up this concept of care coordination for both the fire drills and more and more for the black holes. Again, I said we're also going to be studying those difficult patients at an intense level to try and understand how as a system we can do better for them using the technology we have.
All right, what a great panel. So please join me in thanking our speakers.